Okay guys, welcome to our respiratory history and assessment session. So we are going to build on some of the assessments that we can do and the history taking that we can do for these respiratory patients. Again, we're just going to review over our primary survey. We typically then take our vital signs, our ample survey, OPQ or ST if necessary. Again, we take a big history. We inspect and then to a lesser extent percuss, palpate and auscultate. Just to review over the FEC guidelines for what we're able to do. So again, the EF4 is able to take some SpO2 measurements and respiratory rate, which are vitally important. EMT, again, able to do a little bit more by taking the temperature, but not able to auscultate or percuss or use end-tidal CO2. Again, the paramedic is able to auscultate and typically doesn't percuss and typically doesn't use end-tidal CO2, but can do it sometimes. And again, the advanced paramedic has all these ranges of assessment measures within their scope of practice. Irregardless of what level, it doesn't matter. Asking some key questions and getting some key history is actually, you can figure out what's going wrong in 90% of these cases. Again, on your initial approach, you do your scene size up. You're looking at the whole environment. You're looking at the way the patient is presenting and the way they're positioned. You're looking at the surroundings and get a bigger picture of things. Some of the things that you could see, when you come across these patients is, you could see some inhalers beside their bedside or in their pocket. You might see some home oxygen. You might see some medication. You might see a nebulizer machine. You might see cigarettes in often the cases, or the cigarettes even on top of or inhalers even on top of cigarettes. You might see CPAP or BiPAP machines. You might see that the patient has a tracheostomy, maybe ventilators, maybe suction, and then, environmental conditions, smoke or fumes. So these are some of the things that you can see, and some of the with their surroundings. Just literally on walking towards these patients, you can see lots of these things. Again, we don't lose sight of our key elements, which is our primary survey. Obviously, we do our airway, breathing and circulation checks. We immediately treat any life-threatening conditions. We try to come up with their chief complaint or their history of their presenting complaint. We build on that then by taking a good full set of vital signs and by doing a very simple secondary survey, which will be our ample survey. Have they any allergies? What medications are they on? What's their past medical history? What's their last fluid or food intake? And again, the events leading up to why you are now assessing or treating this patient. From there, you can get an overall impression. Be very careful if you see any of these type of things when you're assessing these patients. These are some of the red flags anyway, which you need to set alarm bells off. Obviously, if they're not breathing, if they're unable to speak, that they're that short of breath that they're unable to speak, it's a very serious sign. If they're cyanotic or blue-like looking, it can be a very serious sign. If they're very noisy breathing, if they look quite distressed, if they're sweating, if they have poor circulation, if they have poor SpO2, particularly in addition with some other signs, if they have a very increased respiratory rate, if they're that bad with their shortness of breath, they're actually getting tired, or they have decreased loss of consciousness, be very, very careful. These people can be quite sick. At that stage, if you see any of those red flags, and after doing your primary survey, your set of vitals, again, it's typically load and go or stay and play. You can, again, this may be different for different practitioners or for different services, but you decide which one you need to go. Again, just to further enhance your assessment skills, you can use your OPQ or ST, particularly if you are assessing a pain, if they have complained of some maybe chest pain, which can often be the case in this situation. Again, just to refresh over, the onset of pain, what provokes it, what sort of quality is this pain, what region or where is it radiating to, what's the severity, and what's the time scale. Another one that we use is Socrates, which is quite useful. Again, what's the site of pain? what's the onset, what sort of character does the pain, is it aching, stabbing, dull, again, is it radiating anywhere, is there any other associated symptoms? So again, in the case of our respiratory patient, you may get some chest pain with the shortness of breath, and this may be pleuritic type chest pain. Again, the time frame, and is there any exacerbating or relieving factors? Again, we have a number of different causes of shortness of breath, and some of them are what we call respiratory related, and some of them are actually not respiratory related but do cause shortness of breath. Our typical ones that we will often see are COPD, asthma, respiratory tract infections such as bronchitis or pneumonia. Our non-respiratory causes of shortness of breath, congestive heart failure, pulmonary embolism, a cardiac arrhythmia, acute myocardial infarction, anemia, diabetic ketoacidosis, hyperthyroidism, motor neuron disease, some traumatic situations, medication side effects, and poisons. So there are some of the what we call the respiratory and maybe non-respiratory causes of shortness of breath. Again, when we do a respiratory specific examination, we take into account our surroundings, which we've already done. We move into doing a more specific interview, and then after our interview we can inspect their face and neck and chest, and then we can, if it's in our scope of practice, we can percuss and then auscultate. One of the key things to ask for in these respiratory patients is about cough and sputum. If you ask about cough, you should ask, some of the things you should ask is, what's the duration of the cough? Is it something chronic or is it new? Is it productive, as in, is it producing sputum? And what's the severity of the cough? Sputum questions are also very important. You know, how long has there been sputum production? What color it is? Is it pink? Is it green? Is it blood tinged? Is it black? Is it yellow? And is there an odor of the sputum? This will indicate sputum production isn't normal in patients, and they may indicate different things. So it's important to figure out cough and sputum history. Sometimes a worrying sign is hemoptysis. So are they coughing blood? Are they coughing blood? So first of all, you need to differentiate, are they coughing blood or are they vomiting blood? If the answer is yes, they are coughing blood, you should try to figure out what amount of blood that they're coughing, what does it look like, and what's the frequency and time scale of this coughing blood. Again, this is vital information to pass over to a hospital. With some of these respiratory patients, you'll often get chest pain, and again, you use your OPQRST or your Socrates to evaluate the chest pain, and again, you're looking at what site it is, what's the radiation of the pain, what area it is in, is it worse than inspiration, is it not respiratory related chest pain, and maybe is it cardiac related chest pain. So, and sometimes they can be difficult to differentiate. When you're examining someone to see if their breathlessness, again, we also examine their severity of breathlessness. Do they only get breathless when they have to exert, or do they get breathless actually at rest? You need to examine to see if they get breathless at nighttime, often known as paroxysmal nocturnal dyspnea. Do they have any orthopnea? Do they get breathless when they lie down? Is there any particular triggers? And again, you may have already found this out when you, in your environmental scene size up. Is there anything that triggers this breathlessness? Is there anything that makes it worse, or is this worsening breathlessness over a period of time? Are they wheezing? And again, is this getting worse, or is this a new onset? Some more questions to ask, and again, you can ask about medication, and you've probably already done this in your ample survey, but again, you can build on this and you can ask about the compliance. Again, some people have poor compliance with inhalers or poor compliance with medication in general. You can ask about the usage, are they having in the frequency of usage of particular respiratory medications, inhalers or nebulizers. Is there a family history of COPD or a family history of lung cancer? What's their social history? What's their smoking history? How many packets or how many cigarettes do they smoke a day? What's their occupational history? Is this breathlessness caused by a new or a chronic occupational lung disease? Do they have any swelling in their feet? Is this new or is this worse? And could this be a cause of their shortness of breath? Again, after we've asked the question, and there's loads of questions to ask, and it's really painting a big picture, you can move on to inspection. And again, just simple things initially. Are they obviously short of breath? Are they coughing? Do you see any nicotine stains? What's their colour? Is there any finger clubbing? Do they have any tremor in their hands? Again, when you're inspecting the chest, is there any sort of chest abnormalities? Do they look like they have a barrel chest? When you're looking at their neck, do they look like they have extended neck veins? Is there any scars in their chest to indicate any surgical history? What's the symmetry in their breathing when you're looking at their chest? Again, another important aspect, and again, you may have picked up on it when you're approaching these patients, or when you come into contact with these patients very quickly, you might start to see accessory muscle use, and this will indicate shortness of breath. Again, they may be using their muscles in their neck, their muscles in between their ribs, their intercostal muscles. You might notice what we call belly breathing, using the abdominal muscles for the breathing. You might see nasal flaring, or you might see them using their shoulders or positioning differently for enable them to breathe a bit easier. So again, some accessory muscle uses and positioning are easy to see, and some you'll have to go and actually inspect to figure out if there's any accessory muscle use. So for the advanced paramedics, and you can do some percussion. Again, percussion in pre-hospital field is not always relevant to do. It can be difficult depending on the surroundings. It can be quite good in assessing. Again, the three things that generally we will assess for in the pre-hospital area, is it normal resonant? Is there a dull percussion, maybe indicating that there's fluid or infection? Or are they hyper-resonant, maybe in the case of an asthmatic, or in the case of a tension pneumothorax? And again, another good skill to note and to do is to auscultate. Again, we auscultate several aspects, both anterior and posterior. And again, we keep it nice and simple initially. Is there nice equal air entry? And then again, we try to note what noises we can hear. And again, this is a skill that can be fine-tuned and can be improved on constantly. Again, it's important to note, maybe if you're dealing with paediatrics, that you ask, there's maybe some specifics for paediatrics that might indicate, again, how sick they are. Again, asking for any previous apneic episodes. Was there any episodes of cyanosis? Are they coughing at night time? Is there a history of asthma? Again, if you're dealing with very young babies, you should probably ask, were they premature? Were they ever on a ventilator? When you're assessing them, you should probably ask, when you're assessing them, you should make sure you strip them off and have a look, and have an actual look at their chest and inspect their chest. Have a look particularly for intercostal retractions or belly breathing. This will indicate how severe a shortness of breath they have. Also general effects such as general malaise. If they're febrile, do they have a runny nose? And again, what's their interactivity? Do they look dehydrated? And be very careful when dealing with young kids and very young babies if you particularly see any of these signs. So when you're gathering up all that information, you can get a huge amount of information, and it's building on what you've done from your primary survey and your ample survey, and you should be able to formulate a working diagnosis. And then again, in the formulation of that working diagnosis, you should be able to sort of create a clearer path for what treatment options that you might want to undertake. Thanks very much.